So I met many of you yesterday, and I'm pleased to be back. For those of you who weren't at the keynote address yesterday, I'm Dr. Lois Krahn, and I am a psychiatrist and a sleep medicine specialist with a long-standing interest in narcolepsy. And so what I'd like to do is take some time to sort of talk about some of the issues surrounding psychiatry and narcolepsy and mental health. And I'm going to start off with a few points that may seem a little bit off topic, but I will at the end explain why I included it. And so let's go from here. I do research, and I have to figure out how to make, how about the big green arrow? Would that work? Okay. So like many clinicians, I am also a researcher, and we do clinical trials, and none of this work will come up today. I see that Takeda is misspelt, my apologies there, with the exception of the first one, Axome. And the reason that that one will come up is the investigational agent happens to be an antidepressant. So just be aware that I'm involved with a clinical trial. I try not to be biased, but it's you to judge whether I am successful or not. Many sleep physicians, families, and patients sort of feel this way about when a person is miserable. Now, thankfully, the first picture here is of a happy dog, but the one that looks very similar is labeled as depressed, where this is just a difficult topic, not only for family members and physicians, but sometimes even the affected person to say, why am I feeling this way? What is it and what can be done about it? And I think that that's compounded when a person is living with narcolepsy and is trying to navigate their day in the setting of sleepiness and cataplexy and maybe had a terrible night the night before. So, this is a very difficult way to live your life. I do think we have learned a lot about narcolepsy because of what we understand about depression and vice versa. So you all know that narcolepsy has been understood to be a sleep disorder for more than 100 years. And there have been some very exciting research developments, including the fact that we're now sort of revisiting the role that some antidepressants can play with or without depression. And we still are learning more. So that's the upside. I do want to just take you on a little tour of REM sleep. Now, we've all experienced REM sleep. Hopefully where it belongs at night, but many of you have experienced where it doesn't belong, partial REM sleep during the day. REM sleep was first detected in about the 1950s by some very clever people working in one of the first sleep laboratories. But it was a psychiatrist who recognized something that we really use day in, day out when we diagnose narcolepsy, that patients with REM sleep that occurs early on during a sleep episode, so we call this a SOREM or a sleep onset REM episode, have something else, and that is a sign of narcolepsy, and we now view that to be a sign of sleep state instability. And we view that as one of the major features of a multiple sleep latency test, an MSLT, which we use currently to diagnose narcolepsy. So one thing I like to include is what REM sleep looks like. And this is an image that comes from our sleep center at the Mayo Clinic. And you can see on the part of the slide closest to me that especially, so the top two lines are eyes, the middle three lines is EEG, then you've got muscle movement, and at the bottom is thankfully a very boring signal of EKG. Nothing's happening there. But if you look at the chin line, second from the bottom, you see a lot of action. And then it stops. And if you look up, you see that the eye line, which was previously pretty boring, has those movements. And this is an image taken from a multiple sleep latency test of a patient who is entering REM sleep. And it just shows what we look for and what REM sleep looks like in contrast to non-REM sleep. I quite like this image, so thank you for indulging me and letting me share it with you. Here's another image. The top line is of a sleepy person who does not have narcolepsy, probably has idiopathic hypersomnia. And this is a little bit older, so you'll see stage 4 sleep, which we've now decided should be lumped in with stage 3 sleep. And at the very top, if you imagine this to be the skyline of Atlanta, you see there's some skyscrapers, and there often is a line on top of them. And then there's some lower buildings that are either narrow or wide. And then you have some basements, which is when a person wakes up. So the top line, a person falls asleep into stage 1, very light sleep, into stage 2, and then into stage 3, and then wakes up. But the first REM episode, which is the skyscraper, is about an hour after this person went to sleep at night. The second line is a patient who has very severe cataplexy in the setting of narcolepsy. And boom, to use one of Dr. Mignot's phrases, this patient enters REM sleep immediately. The other thing that's kind of interesting, that is still a matter of debate, is unlike the top person, the bottom person can't stay put. If you look, that skyscraper is very fragmented and can't even stay in that state of sleep. So it's just in and out, which likely means that that person is awakening all the time and is remembering dreams and may well wake up in the morning and say, what a night. I had these terrible, vivid dreams, and just feels beaten up in the morning. The reason I show this to you is because antidepressants almost uniformly will alter the amount of REM sleep and push it down so that there's less REM sleep. Now, whether that's important or valuable for a person who's being treated with depression is an open question. No one really knows. But we do know, and some of the experience dates to this era when we didn't have nearly as many medicines as we have now and soon will have, that if we use an antidepressant to push down REM sleep for a person with narcolepsy, that we can help some of those dreams go away, we can control cataplexy. And so that is what makes this topic so interesting, that sometimes a person has one or two different problems, and we can select a medicine that can help with both problems, the depression or the anxiety, because antidepressants, in spite of their name, can be used to help with both, as well as with the narcolepsy. So, living with narcolepsy, I do not need to tell you, is tough. And there have been many studies, this is an older one, but it's a good one, where a quality of life scale was used and just looked at what is it like for a person with narcolepsy. And this will come as no surprise to you, that a person just has a hard time doing what they need to do, which we call role functioning. They have a hard time doing physical things. They just feel less vital and energetic. Well, that's not hard to see. Their social activities are impaired. They probably would rather take a nap. And this is notable given the topic, they can have mental health problems, so depression, anxiety, and that, a disabling disease like Parkinson's disease is actually quite similar to narcolepsy, although Parkinson's disease, I would argue, gets more attention in part because most people with Parkinson's disease, you can tell they have the disease. They have a tremor, they may move in a very rigid way, and a person with narcolepsy very often, which has its benefits, can hide the fact that they have a serious medical problem, but that also means that if you're not doing what someone thinks you should be doing, they may not understand that you've got a really good reason because you have a medical disorder, narcolepsy. Now, what makes this topic difficult is that there's a lot of overlap. And this is not based, when these diagrams are made properly, somebody has percentages and the bubbles represent how important something is relative to something else. Well, I wasn't able to locate any data to allow me to do that, and I can tell you my graphic art skills fall short too. So this is very much just an impression, and there's one that I had a little fun with, but I think is really true. Or did I take it out? It may not have fit, which is just having unfinished business, which is, just can't get stuff done. And that could be due to narcolepsy, it could be due to depression, it could be anxiety. And I think that sometimes we just have to settle on not precisely being able to label what the problem is, but hoping that we can find a solution to help make it better. So I want to just run through what major depression is in the eyes of a psychiatrist. Because sometimes when I used to work as a psychiatrist, and now I do sleep medicine full time, I would be asked to see a patient, and the reason for seeing a patient would be, this patient's crying. Well, crying might suggest that they're sad, but it's actually not considered an official symptom, because some people cry when they're happy, some people cry when they're sad, some people cry when they're momentarily sad, and they get it out of their system and it's gone. And so long ago, there was an agreement, and this is the basis for the DSM-5, which is sort of the rule book for psychiatrists, that in order to be considered to have major depression, you've got to have a couple of symptoms. Actually, you've got to have 5. And this is the list where the 5 are drawn from. Now, as you look at this, you'll see some of them can overlap with narcolepsy. So no energy. Too much energy likely doesn't apply to the people in this room, but no energy. Eat for comfort, and some people eat when they're tired. Sleep problems, okay, well, if you've got narcolepsy, ding, 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 you probably already have at least 2 of those. Now we start getting into things that are a little more specific for major depression, anxiety and moodiness. And you may say, wait a minute, you're talking about major depression. Well, there's also a lot of overlap between anxiety symptoms, anxiety disorders, major depression, and the treatment for all of the above. That's another very blurry boundary line where sometimes we just have to say, we can't exactly put our finger on it. Hopelessness, now that's getting a little more specific for major depression and is out of the classic narcolepsy realm. If it's a persisting hopelessness, we all, every once in a while, will have a moment where we say, good grief, this elevator isn't going to come. It is hopeless. There's no way I'm going to be here by 11 o'clock. It's beyond my control. Well, that's very transient. I don't mean to trivialize, but we all have those moments. But a person who has major depression and feels hopelessness really is feeling that way day in, day out for weeks. You can't trust your own perceptions. So some people with major depression can get actually a little bit wary or paranoid and think that people are talking about them or following them. That's a pretty severe form of depression. That one can sometimes overlap a little bit with a person who's woken up after a horrible, irrational dream, to a degree, not entirely. Concentration difficulties, well, that's certainly the domain of narcolepsy as well as for major depression. And then a lack of pleasure. Well, a person who's completely tuckered out, no energy, has a hard time enjoying something. They'd rather take a nap. So there's overlap there. And so that's where this gets to be a rather difficult topic. And sometimes there are a few other symptoms that also can overlap: fatigue, suicidal thoughts, not quite as core as the ones I just mentioned. So I'm now going to share information that's going to seem hopelessly obvious. But, it's important that this work be done because it helps shine a light on the issues, and it helps motivate researchers to take a much closer look. So how common is it for a person with narcolepsy to also have depression. And this would be major depression, because these are research studies done by people who are really using some pretty clear terms. So they would have used DSM-5 or its predecessor DSM-4, or if it's old enough, DSM-3 terminology. So it's not just somebody who's sad, it's someone who has at least 5 things going on. And a meta-analysis is actually a pretty powerful study when done well, because a researcher then will look at all the research and find ones that are well done. And in this case, they found 31. So this is sort of, a project of projects. And they found 13 that compared patients with narcolepsy to controls. So that helps just improve the quality of the information. And they found 32%, so 1/3 of people had full depression or had a lot of depressive symptoms. Well, that's a lot of people, 1/3 of people with narcolepsy. And their conclusion, shocking, was that people should be closely monitored. The problem is it's not that easy to monitor because of all this overlap, and it's not that easy to say this is enough that we now need to pay attention to it more and do something. So there was another study. This is just a single study rather than a study of studies, where they had 51 patients with narcolepsy and 35 healthy controls. They gave them a questionnaire, which is very common when it comes to depression research. And what they were looking at, what form did their depression take? And they found that people, surprise, surprise, had trouble with their attention. And surveys aren't the best way to detect that. So the fact that a survey detected it probably means it's the tip of the iceberg. And they found the same thing. 1/3 of people had both sleepiness and depression. And they concluded, again, that this needs attention, needs more study. But they also concluded, which I heartily agree with, that we need better ways to measure this. Because we need, and this has not happened yet, although I know it's been worked on, we need ways to detect attention and concentration problems so that hopefully we can help make them better with medicines, whether they be medicines for depression or medicines for narcolepsy. So now this next study is a little different than the ones I mentioned because they branched out and also talked about anxiety. And they did what's called a case control study, where they just find somebody who's eligible and then compare them to somebody else. And they found 60 patients, and this is very often done. They actually have more controls than they have patients. And again, they found that 30% of patients either had depressive disorders or symptoms. They went into the realm of anxiety, and panic disorder is a serious and very unpleasant form of anxiety disorder. They found that more people had anxiety symptoms, which is true for people without narcolepsy. Anxiety disorders are more common than depressive disorders in the community at large. They found, and this is not a surprise to me, that social anxiety was very common. And I think for people who live with the reality of cataplexy, that this makes a lot of sense. I've certainly had patients tell me that they have an upcoming family wedding, and they either want their medicines to be adjusted so that they have better control of their cataplexy, or they plan to sit in the far corner where no one can see them because they kind of dread the meeting old family members and friends and the toast to the bride and groom because they're worried they may have cataplexy. And so I think that having the experience of cataplexy really can feed into some social anxiety. And this study did not find any difference in terms of, do older patients have more difficulty? Do men have more difficulty? If you've had narcolepsy since you were 12 years old, do you have more difficulty? And although I'm not quite so sure to think about this last one, they said no difference in medication use. I think that's a very big topic. And it's hard to imagine that with a sample size of 60, that they sort of had a big enough sample size. And if you don't have a big enough sample size, a research study can say something isn't present, and it just means it wasn't found because it wasn't a study that was designed to be big enough to find it. So you have to be a little careful sometimes when nothing is found. So when I and my colleagues meet a patient who has narcolepsy, we, of course, try to help them to reduce their EDS, excessive daytime sleepiness, to prevent cataplexy, or at least make it as infrequent and mild as possible, to reduce disturbing dreams, which can fuel depression if you wake up in the morning after having just had some horrible dream. That's a terrible way to start the day, and it's not hard to imagine that you can't just shake that off and sort of get to it, that you've got this negative cloud that you start your day with. To improve nighttime sleep, so you don't have like the patient I showed you who's just constantly waking up. And then mostly to just help a person get things done. Improve daytime functioning, and just their feeling, their esprit de corps. These are all familiar to you. These are the different medicines that we have used for a long time, and there are more that are becoming available. The one that I just want to highlight on this list is our antidepressants. I do want to add a caution, though. So at my institution, and in many other places, we have used stimulants for a long time to treat narcolepsy. And this is an old ad from the 1950s. This was an era when methamphetamine was just made available, and it was before the DSM-5 existed. It was before the FDA existed. So anyone could do what they wanted in an ad. Nobody was going to correct them. And I'm not sure what the problem is that the patient, the woman, has, but methadone is supposed to fix it. And so we have to be a little careful, because sometimes the amphetamines can make a person feel better, and they can be appropriately used, but we don't want them to be sort of used too much or too high a dose to help a person, when a better, safer medicine like an antidepressant perhaps should be used if the reason they're being used is for depression. So just a little caution there. And there certainly is a long history of people with narcolepsy who have depression or who don't have depression, who have anxiety disorders or who don't have anxiety disorders, benefiting from antidepressants. And it became much easier to treat patients. And this Time magazine cover is from the late 1980s, when we developed the first SSRI, and it was a real breakthrough. And up to that time, we had antidepressants, tricyclic antidepressants, monoamine oxidase inhibitors, and we still have them. But we now have many more options, which gives a psychiatrist and a patient more tools to choose from. So antidepressants can be especially beneficial for patients with narcolepsy because they can suppress REM sleep and cataplexy, so you can kind of get double benefit. They're not FDA approved for that purpose, although the Axsome study is seeking to maybe cause me to change my slide if they're successful with their clinical trial. The ones that work better are not the SSRIs, although they have value, but the ones that work on norepinephrine, not so much serotonin, and they're listed here. They're old ones that we used to use a lot: imipramine, protriptyline, clomipramine, and the newer ones, venlafaxine, and I should actually translate this into English, Effexor, Cymbalta, and Strattera, which is an antidepressant that in the United States is not approved for the treatment of depression, but is approved for the treatment of attention deficit disorder. But knowledgeable physicians and patients have relied on it because it can be quite helpful in a narcolepsy patient population. And then the one, if approved, if the studies are successful, its name in other parts of the world is riboxetine. It right now has a code name, AXS, because it's not yet approved here in the United States, and the safety and the value needs to be demonstrated. So I wish I could now go into slides as to how well do these work. And all I can say is it's a little hard to say, but we do have one other topic, and this is Sunosi, or solriamfetol. And, you know, that is a medicine that actually started its pharmacologic career being thought that it would treat depression because of how its chemistry is. And now it's, you know, uniquely being promoted as a medicine for sleepiness, whether a person has narcolepsy or obstructive sleep apnea. But, you know, inquiring minds wanted to know, this was not the primary purpose of the FDA trial, but did it help people who had narcolepsy and depression? And they actually also looked at people who had obstructive sleep apnea and depression. And they looked at the rating scales that had been collected as a part of the FDA trial to prove it helped with sleepiness. And they found, unsurprisingly, sleepiness improved. They found that people functioned better on this medicine. They found no difference in side effects. So although they could not prove it helped with coexisting depression, that was not the point of the study, and it wasn't quite designed for that purpose. It may be something that is a benefit. So it may be a narcolepsy medicine that does double duty because of just the way that particular medicine works. And I include this slide, and you can see this is a pretty new one, 2022, because I hope it's the beginning of more researchers asking, you know, how well does the depressive part of a person's problem respond to treatment and not just focus on the narcolepsy? Because we all know that living with depression is utterly miserable. There are other options. Reboxetine is listed here. We don't know enough about some of the newer medicines like the histamine agents, pitolisant Wakix. If that helps with depression, I hope somebody looks into it. There's a lot to be learned about the yet-to-be-tested orexin agonists. And then there are some enterprising people who are trying to develop psychotherapy for hypersomnia, and there would be some overlap for people who have anxiety and depression. You all are likely aware that cognitive behavioral therapy is used to treat insomnia. And some of the same tools will help people who have depression. Well, Dr. Phyllis Z's group has a little bit looked at cognitive behavioral therapy for hypersomnia to see if there can be a way to introduce techniques that may benefit a person. So I don't have to do as I've been doing, which is I've been mostly talking about medicines. And there are things besides medicines that can make a difference. So I know we're about at the question and answer. I just want to say that there's a lot of blurriness here, even for someone like myself who's been doing this for quite a while. And I think the blurriness will always be there to some degree. It's a little hard to sort out what is narcolepsy, what is depression, what is anxiety, and it's even harder to talk about the things that I did not talk about because there was nothing but my own personal experience. For a person who has both narcolepsy and bipolar disorder, or narcolepsy and schizophrenia, or narcolepsy and autism, although some may say autism really is more of a neurologic disorder, and I would agree. It's often treated with psychiatric medicines, and it has major problems for a person functioning. And we know almost nothing about that. We have good options. I hope we'll get better options. And please, don't go alone. Seek support. Many depressive patients often say, I want to just be private about this. I don't want to talk to people I trust. And then when they do talk to people they trust, they're a little surprised, and hopefully this would be the case for you, that people are they concern, they want to help, and the person who's disclosed and talked to the right person feels a little better. So getting support, whether it be from your family, friends, or a therapist, is important too. So with that, I am available to answer questions. And thank you very much, and sorry about my elevator issue.
Have there been any studies for treatment-resistant depression and the use of transcranial magnetic stimulation, and how effective would that be for someone with narcolepsy?
Excellent question. That's very hard to answer because if I really just answered the question, it would be no studies. However, transmagnetic stimulation therapy, which is basically putting a magnet to shift neurotransmitters without a pill. So we've used medicines to sort of change the pumping activity of cells to increase or decrease the amount of neurotransmitters. This is using a magnet. And then, of course, one other old treatment that still exists and saves lives is electroconvulsive therapy, where it's more than a magnet, it's actually a seizure that is created. That has not been studied, and there may be a reason why. There was a study in the 1990s done by a group in Germany where they used a form of transmagnetic stimulation therapy and triggered cataplexy. Now, they used a very strong form of TMS. They had a person who was on, and I think it was probably on clomipramine. The person was on an anti-cataplectic medicine that they abruptly stopped. And, if you suddenly stop a medicine that suppresses cataplexy, it can rebound and come back. And so they probably weren't doing it very well. But unfortunately, that one study from years ago scared people off. Now, TMS, I think, has come a long way. The goal of all therapy, but especially something like a magnet, is you want to find the least powerful magnet that's going to do what you want it to do in order to minimize side effects. So I do think in the intervening years, they've been working on doing repeated magnet exposures, so repeated in a single session, and then day after day. So a person who gets this therapy goes in to see their doctor like 5 days a week for 6 weeks. It's a pretty highly disruptive but beneficial therapy. And so I think probably it's safer than that old report would reflect, but I think it's caused people to sheer away from this topic. Now, my colleagues who do TMS tell me that TMS is soon going to leave the domain of the doctor's office and that there may be home TMS units. So a person would give themselves TMS, which would certainly be less of a nuisance. I have to think that that would probably be a less powerful device in order to be safe. So that might be a device that's even a better choice for a person with narcolepsy and cataplexy. I will say I don't see a downside to a person who has narcolepsy without cataplexy, but because they wouldn't be at risk unless they have their first ever cataplexy event. So that's been a problem for that. If I were talking about depression, put aside the narcolepsy, I would say this is a very promising, non-medication, scientifically based, effective treatment. But when we add the narcolepsy in, it gets, unfortunately, a little more complicated. An excellent question. Thank you for asking it. I just about threw that in, and I thought, the signal person will start to throw up red signs saying, I've gone overtime.
Doctor, we've heard a lot through the weekend about how there are misdiagnoses, how the mental health medical community, the sleep disorders medical community are not as tightly connected as they should be. There isn't as much information. I'm wondering if you can give some thoughts or advice on how, given that, and given, as you've shown, how much comorbidity there is between these conditions, how should people approach trying to get integrated treatment for what might be a mental health disorder and obviously a sleep disorder because they have narcolepsy?
That is an excellent question. And I have an idea, and unfortunately I just haven't had the time to pursue it, although I've started a little bit. And so I'll just give this idea, because maybe somebody else can do it faster, better than me. I have wanted, working in a large metropolitan area with a large university that teaches therapists of different types, to ensure that narcolepsy is included in the curriculum of the university. so that any graduating therapist will understand the symptoms of narcolepsy, understand this overlap. We've done it for future physicians, so in medical schools, but I'm not aware too much, and probably it happens within PhD programs for psychologists. But many therapists aren't PhD psychologists, they are social workers. And they can be excellent therapists, but they probably don't know much about narcolepsy. And so I think it would be fantastic if it was in the curriculum for the next generation. Then the other thing I've done, wanted to do and done a wee bit, is reach out to therapists and said, are you interested in working with us? We have one therapist at where I work for the whole team of doctors, not just the sleep team. And it's great to have one, but what can one person do? I would love if we could create a network in the city of Phoenix of interested therapists who had a good understanding of narcolepsy that we could collaborate with, and sort of have an alliance of these therapists. I think that would be wonderful. And so I think, that would be something that could be replicated in many places. And these days, with all the telehealth and teletherapy, it should be possible to see, for those of you who live in more rural areas, to see therapists who aren't perhaps in your community. So I think that that is an idea that has legs, and it could be nurtured. And I would love if, one thing that slowed me down is I haven't really found an ally in the therapy community to sort of co-partner with me and have this take off. But I think it would be a very interesting, important thing. Because sometimes the symptoms of narcolepsy are misunderstood. So one of my patients, I'll just tell a story, had narcolepsy type 1 and was taking oxybate. And unfortunately, her husband was very resentful of how her evening revolved around bedtime and taking the oxybate, and she slept so soundly. And it became a real issue in their marriage. And, I would like to think that had he understood a little better how tremendously effective oxybate was for that patient, that he could perhaps understand that it was worth it. But he had a lot of resentment, and they're still working it out. But that's the kind of thing where a marriage therapist needs to know narcolepsy and oxybate therapy in order to really perhaps help that couple work out that particular issue. But
that's great, and I think that's very encouraging to know that the kind of work that you described that you're doing is happening elsewhere. I'm sorry, I didn't realize there was someone else. I'm just going to do a quick follow-up, which is, we've also heard a lot about, as we've said, the misdiagnosis. People with narcolepsy often begin their treatment journey with a mental health professional. Mm-hmm, mm-hmm. And often, as we've heard, that mental health professional may not be that familiar enough with narcolepsy. How would you advise patients who are in that situation? I mean, we know that doctors can sometimes be defensive and so on. That how would you suggest that people with narcolepsy who feel like, I've read a lot about this and I think I may have this, could get that doctor, that mental health professional who may not be that familiar with it, to get them to accept that maybe this is what they have and so on?
Well, that's very hard because, regardless of our profession, we're all likely to see what we're trained to look for. And so if a person comes in and says, I'm tired, a therapist or a psychiatrist or a psychologist may say, well, you must be depressed. Let's treat that, and hopefully you won't be tired. I think the words we use make this harder, because words like tired and fatigue are used a lot in depression. I think if a person can use the word sleepy, that often sends a different message And, sleepiness is when you actually do close your eyes and fall asleep. So it is a little bit of a different concept. But in the English language, as we use it, a lot of sleepy people say, I'm tired, I'm fatigued, and that muddles the issue. So if I may say, call yourself sleepy and pass the advice to others, use that word, because someone who's aware of narcolepsy, or for that matter of sleep apnea, should sort of have a little alarm go off. Sleepiness, now I did say the DSM-5 has sleep problems in there, but, if there's a lot of sleepiness, you really need to think maybe it's not depression, maybe there's something else there too. I have to say, I've had people, I once had a man come to see me who was seriously depressed and suicidal, and it was an emergency visit. And he couldn't stay awake. Now, he didn't have narcolepsy, he had obstructive sleep apnea. But the doctor, very good doctor who sent him to me, said, and I was at that moment on the psychiatry service, so whether that doctor knew I was a sleep doctor or not, I don't know. But the patient just couldn't stay awake, and it was like, well, yes, there probably is some depression here because this person has some hopeless suicidal thoughts. But he is so sleepy, and he had profound obstructive sleep apnea, and with CPAP felt much better. Sometimes it does happen, but I wish it happened more. You've been very patiently waiting.
I'm a patient.
The English language is fun.
Yes, it is. I guess kind of going off, it took me a long time to realize that one doctor doesn't cut it. So I had to pay a really high premium to have a sleep specialist, a psychiatrist, a psychoanalyst, and a general practitioner, that they were all in the same system, so they knew exactly what treatment they were giving to me. The unfortunate part was that when I got on disability, I lost all of that. And
Yeah.
And the social workers are so overworked. The vanilla files are up to here, and they don't give us a chance to even write the notes, and you can't overstay because there's a line of people crying. And to get outpatient treatment, it took me months just for them to tell me that you can't miss more than 2 days in the 8 weeks. And me trying to explain that's an impossibility. I would be able to work if I could. And they just kind of told me, well, figure it out, figure out the sleep thing, and then come back. I'm like, okay.
Yeah.
But I guess my question was, you mentioned bipolar and depression and all these things, and I actually had to. That's what got me almost accepted for disability, because at the time I would say it's like narcolepsy is just not trendy enough yet for recognition. And when I took this 4-hour exam where it's just like it tests your visual, all these things.
That would be neuropsychological testing, a 4-hour
Yeah.
sort of, paper and pencil or exercises. Yeah.
And I actually had to stop at the 2-hour mark because this guy was a Gator football thing. I'm from Florida State, whatever. It just got in my mind, and I couldn't stop my auditory hallucinations. So
Yeah.
I had to come back. But I think I've been turned down by a lot of psychiatrists because of a liability because of the medications they gave me. And I do suffer from PTSD and borderline personality disorder, and very severe anxiety where I have physical manifestations of it, and bouts of depression. Actually, today was a really, really bad morning, and I don't know what to do about it, because it seems like everything that I need to take to fix one problem, it's just creating a dependency on another medication.
Yes, I mean, the system that we have is really not a system. And it becomes really apparent to a person who has both a sleep disorder, a medical disorder, and a psychiatric disorder. And unfortunately, in many larger cities, psychiatrists or therapists sometimes don't accept any insurance or don't accept government insurance. And, that's their right. Some government programs don't pay enough to cover the office expenses, so you can sort of understand why they wouldn't be very keen. But the bottom line is, it can make it tremendously difficult for a patient to find the kind of network with people working together. They exist, but often they are hard to access. They may not have appointments. They may not take the insurance you have. And I don't have a good solution to that. The one small idea I have that may or may not work is if there is a medical school in your community, to see if there is a clinic there. They sometimes will take a patient and they will have you see students, but the students are supervised. So that's one way to sometimes overcome this. I know in the state of Arizona, when some of my patients become disabled, occasionally I've actually offered to see them, and we call it access, the Medicaid program won't allow that. And the reason is that they aren't so worried about me. They're worried that I might prescribe expensive medicines that then they would pay for. So the systems can be really intrusive. And I'm always a little sad when some of my younger narcolepsy patients turn 26, because then they can leave their parents' insurance, and sometimes they go on disability. So it's a hard thing, and I don't have a good solution other than try a medical school to see if by chance they would have a clinic that you might be eligible for. Maybe you're lucky and in your state they have better services, but from what you describe, it doesn't sound that way, and it sounds like they don't really have social workers who have time to do therapy. The social workers are really doing traditional social work with all the forms you describe. So I wish I had a better answer, other than look towards some of the medical schools and universities to see what they may have to offer.
Thank you very much.
And all the best.
Thank you.
Hi, I have a question about how do you know when you've maximized the medications to improve your symptoms? Because for me, when I started, I've been on modafinil and Xyrem for the past 8 years, and then in the spring I realized I could take a second stimulant in the middle of the day instead of drinking caffeine, and that really helped. So my question is there a way to figure out if you've maximized the medications you're taking without just taking all of them?
Yeah. Well, I have an idea, but I can't, it doesn't exist. So our last speaker mentioned the neuropsychological testing. I mean, that is one way we determine if a person has attention problems, which likely, if someone is pretty well treated, so they're no longer falling asleep, but they're not quite where they could be, should be, it's probably the symptom left here is attention. And the traditional way of sorting that out is to have a person take 4 hours worth of testing. Well, the problem is a sleepy narcolepsy patient may not stay awake or may have, other symptoms that distract them from doing well, and it's hard to do that test. In the perfect world, I would love that there be a game. And it would be, sort of a Tetris game or something. and a person, we have this be a medical device, and a person play the game, and we look at how fast they can play it and how accurate they can play it, and that it be done much faster than a 4-hour testing session, and that be a tool that tells us if a person's on the top of their game or not. Sorry about the pun. I would like to think that will be developed. In the world of brain injury, there's been some progress on this. There's something called the King-Devick test, which is now on the sidelines of many soccer fields and football fields, where if a person is hit in the head, they will sort of connect the dots, and the device measures how quickly and accurately they do that. And if they fail the test, they're then told they may have a concussion and they ought to go to the hospital, and they certainly shouldn't play. And if they're able to do it well, then they can, they had a bump on the head, but it doesn't seem to be serious enough, and off they go back to play. I would love to see something designed for sleep symptoms that would be the same, because I think there's a huge need. And it's very hard to know, am I on enough? Do I need more? Or am I maybe on too much? And could I get by with a little less? And I think we need some better tools. And the 4 hours of neuropsychological testing, in my opinion, is not quite it. It's got to be a variant of that hopefully is more portable. So for the inventors out there, please go for it.
Thank you.
Hi.
Hi.
Hi. I wanted to share just two quick thoughts. One is we have a car that gives feedback when you're getting tired.
Yeah.
Which I think, as much as we have like ABS brakes or airbags, that would be a wonderful thing to be adopted across the board. The other thing I just wanted to share is something you've probably seen many, many times, which is since narcolepsy, when it first emerges, can look like depression. So many people start on an SSRI, and then it masks the cataplexy, and then you go for years before you figure out that that it was something else, or perhaps in addition to.
Yeah.
So I just wanted to share that. I just wondered what advances might be for awareness of that.
Yeah. This is one of the challenges, and so a person is not doing well, not getting stuff done, and they go to see their primary care doctor, who says, A, you may have depression, let's help you. B, you may have attention deficit disorder, let's help you. And puts a person on medicines that could be used to treat narcolepsy. Well, they help a little, but not enough, and the person, says, I'm just too sleepy. And that code word alerts the right people, and they come in for testing. One of the challenges, and I hope we understand this better because it needs much more work, is that then the person is on 1 or 2 medicines that make it hard to do an MSLT. Right. So if we go ahead and do the MSLT on those medicines, the eye movements that I showed you may not develop because the medicine is pushing them down.
Oh, I thought you had to be off medications
Well,
too.
exactly. And so we have to stop the medicines before
Right.
we do an MSLT. Well, that greatly adds to the hassle of the whole thing.
And distress.
And sometimes I meet a person and I and the patient feel it really is not a good idea to stop the antidepressant because they've had such a hard time with depression. Well, then what do? We sometimes will do an MSLT with medicine. Where I work, we can quite easily order a spinal tap and do an orexin level, but that's only really of value for a person where we think they have narcolepsy type 1. That's not at all of value for narcolepsy type 2. So we have a hole there. Yeah. Now, my understanding is that there is a research study underway that they're going to have people come in on whatever medicines they're on, and I don't know much about this. So whether it's both for antidepressants and for a stimulant that are used for other things that a very well-meaning physician has given to try and help. They're going to do MSLTs on the medicines and just measure how big a problem is that. And maybe that this whole thing has been overblown Scientifically, there certainly are concerns, but maybe it's not that big a deal. And occasionally I've had a person, and I saw someone just in the last week or so, who just couldn't come off the venlafaxine. And this person took venlafaxine for anxiety. And when we tried to discontinue it to do the first MSLT, this person had never been worked up for narcolepsy, they just couldn't function. So we did the MSLT on venlafaxine, and it was still positive. And so although it's not, clear-cut, in medicine many things aren't clear-cut, we did, diagnose narcolepsy even though he was on an antidepressant before, on the day of testing. It was a lower dose than it had been. And it was the only way to help him. And now he's moving on to medicines for his sleepiness. And I think he's going to do quite a bit better in every respect. Being sleepy is not good for anxiety. So I think that he will be in a better place soon. But, it's hard. It's hard for patients and it's hard for the physicians.
Thank you.
You're welcome. Thank you for an excellent question.
My official diagnosis is GABA-related hypersomnia. So my question is, though, I also have common variable immune deficiency, which I have passed on to my son, who's type 1 and has also sleep issues, undiagnosed. But I'm wondering, are there any studies based on these severe immune deficiencies? I mean, I only make 4 antibodies, so I'm doing sub-Q, IgG at home every month, which has kept me alive. And I do feel some improvement once I do my infusion every month, but I can't help but think that they're related somehow. But I haven't seen anything.
Well, it becomes difficult when a person has one extremely rare condition and another. I don't view narcolepsy as rare myself, because, 1 out of 2,000 people, that's not rare, but one uncommon condition. And then when you're looking for people like yourself who have both, it takes a very long time to come up with a large enough group. And I did mention a little bit that if you have too small a group, you can do the research study, but you won't find anything, and then a researcher may be tempted to say it's not there, when in fact they didn't have enough people to find what they were looking for. So it's really hard to do research in combined diseases. Now, I do hope in our era of having better and better data tools that maybe larger data sets will be developed and that it will be more possible to look at some of these things. I must admit, I can't remember the details, but there have been a few studies of other autoimmune diseases. So in my practice, I have a few patients who have Crohn's disease, who have rheumatoid arthritis, who have psoriasis, or have all of them, have multiple autoimmune diseases and narcolepsy. And I've gone looking in the literature, and I know that there are 1 or 2 papers, and this is where I don't think they said much of value, because otherwise I think I'd remember it, where they looked at people who had rheumatoid inflammatory autoimmune-based arthritis and narcolepsy to just see, because one of the questions I had is if we treat the autoimmune process, so someone has Crohn's disease and psoriasis, which can go together, and they're on a very expensive, we call them biologic agents, could that have some benefit for their narcolepsy? The reality is it probably won't if the narcolepsy developed years ago, because the injury happened. But it's an interesting question, and it's not been looked at enough, in part because it's harder to study people with less common conditions. That is not a very satisfactory answer for you.
Well, because I also have 3 other autoimmune that are rare.
Yeah.
And so my rheumatologist just dismissed me and said, anything I would do for you would kill you because it would reduce your primary immune system even more.
Yeah.
So we just treat symptoms, but it just seems like I'm meeting more and more people that, as I go to things, and it just seems like somebody should be looking at that as.
Now, for some rare diseases, one of my cardiology colleagues did something very interesting, and this was a few years ago, but she was studying a rare heart disease in women, and she used social media to sort of put out a call, and this has been done for some other very rare diseases, to say, if you have this disease, please sign up on this site. And actually got enough people to sign up that allowed them to do some research. And I certainly know, occasionally parents will have a child who has a congenital disease. And they will do genetic testing these days and find something. And then occasionally, through social media and other mechanisms, families spread around the world have connected. And sometimes these are really rare things where like 3 families around the entire world find that they all have a child with the same genetic defect, and then they're able to sort of learn more as a group of 3 than a single. So that's one thought. So all the best.
Let's take one more question from this gentleman, and then we will wrap it up.
Thank you for your presentation. Earlier, I think I heard you say that it's not an ideal practice to be using dextroamphetamines for wakefulness with all the changes that are coming about. To the extent that people have been started being treated years ago and already on it, what's a way to approach reducing that dependency?
Yeah.
And if you're already, say, taking a Wakix with it, are there other wakefulness things that can be used to support the weaning process and support wakefulness as the amphetamine level goes down?
So, no drug is ideal, and the stimulants have played an important role and continue to play an important role. I certainly have quite a few patients where a stimulant medicine is an important part of their narcolepsy treatment plan. So I'm sorry if I was a little too strong when I talked about that. When I have a patient where for one reason or another we feel that it's time to try something new, and for example, Wakix is an example. Some of my patients on pretty high doses of stimulants, when Wakix came out, I said, I knew we'd been talking about, could we possibly change things a bit? So what I do in my practice, and just like Dr. Mignot said yesterday, don't take this as medical advice, it's just sort of an idea that I'll share with you, is I would add the Wakix, because there's no reason to think that Wakix and a stimulant would immediately cause trouble, but sort of warn the person, we have to be very attentive here, and then would start a very gradual reduction. So I don't sort of reduce first and then add. That might be a very pure way to do it, but I'm worried about the person living their life, driving their car, and how long that's going to take. I tend to have them on the medicine that we want to stop, and then maybe add a slightly lower dose. And Wakix is one where the dose is gradually increased. And so there's one is starting to go down slowly, the other is starting to go up, so there's an overlap there, as long as the 2 medicines can be mixed. And I'm pleased to say that some of my patients who've taken high doses of stimulants for a long time are now on lower doses. They may still be on a little bit of a stimulant, and now on one of the newer agents. And I and the patient agree that that's a sign of success. And we'll keep working on it. So that's my own approach to this. And so I welcome having more treatment options, because it allows us to, no medicine at a high dose should just be left in place. If something new comes along, there may be something better. But it should be done, this is not an emergency. We don't want to create a new problem along the way. So it's a gradual titration. And the one thing a person needs, which I know not everyone has, is a doctor who's able to see them and follow. Now, I don't see my patients all the time, but where I work, we have a portal. And so I'll say to the patient, let's plan on making a reduction every week. And could you send me a note after you've made the reduction? And don't just tell me if you're having trouble, because then I really get a biased view. Tell me how you're doing, good or bad. And that way they don't need to drop what they're doing and have a video appointment or come in. But I have a nurse that helps me, can have a better sense of how they're doing as we do the transition. So I do think a patient portal if your physician uses one, can be very helpful for this kind of thing.
Thank you.
Thank you. Well, my apologies for keeping you waiting, and thank you very much. I appreciate you all coming, and I think a few new people have joined us holding food, so I suspect that there's a lunch line somewhere.